hear us? I'm mute now. Can you hear us, Gav?
He's muted.
You're muted.
He can hear us.
You're muted, Kevin.
He's muted.
He's quite different though, doesn't he, with his...
He does. You look so different with your
Yeah.
nose.
It's a rookie Zoom mistake with the mute on. Morning e te Hauora Tairawhiti whānau.
Morena tātou. Can you start our meeting?
A tēnā tātou, a mīnei tātou. E rio o ngā mano, a tēnei te whakamuinga tutu ki aku, tēnei huihui ngā mātou. Ara hena mai ki au tika ki te pono i a mātou, tukua mai tō wairoa tapu hei manaaki, hei āwhi te āki hoki a mātou. A nei mātou e tōhu nea nui e tuaroaro, a ka tuku I tēnei ino I ringo I te ngō tō mātou kai whakaori I Kraiti. Amen.
Josh, to members of the public who are joining us today, welcome and thank you for participating with us once again, and we look forward to our meeting today and participation in it. We have a reasonably constrained time frame today. We must be finished before 1 p.m. and there are a couple of general business items at the end of the meeting that may take around a half an hour or so. So the aim will be to get our formal agenda finished by around 12:15. If we go straight to the items, we have apologies from Na is coming on Zoom. Is Na here yet? No. He does have to step out for a period for another meeting, and Gavin, you also need to step out for another meeting. Those are the only apologies we've received, and we do have a couple of members who will be arriving a bit late.
Excluding me.
Excluding you. Item 2.1, do any members have an update to their interest register?
I can take my sister off the field. She's in
Okay, thank you. And item 2.2, any conflicts in relation to any agenda items today? No. Okay, thank you. So we'll move to item 3.1, which is the minutes from the open agenda of the 27th of October. Gavin, you chaired this meeting, so can you take this item, please? No, Gavin's had to step off. Okay.
Sorry, I've lost my Zoom nimbleness. All right.
Just if there's any items on the minutes that you want to bring to attention.
Not particularly. There was an action relating to sort of the annual plan work, which is the annual budgeting work, I should say.
Yeah, I think it's on the FRAC agenda action list. Gavin, but certainly hasn't been forgotten.
No, yeah, that was the main thing, that we had an action around our budgeting for the coming year, being cognizant of what we were seeing in the current year. So that's with FRAC for following up.
Does anyone else have any comments on the minutes? And then we will we'll look to approving those minutes. Other than the matter that Gavin has raised, are there any further matters arising? No. Then item 4.1, Jim, can you take us through the action list, please?
Sure.
At page 13.
Yes, so I can just update on that first one there around that suicide event review. I had an update yesterday about that. That's just about completed, so should be coming through for next month. COVID-19 review, there is an update on that coming to completed this month, and so will come up for the board next month. That item about the Morrison Piles is on the agenda today. Performance dashboard, we have updated that as required on the dashboard there, and there is information around immunisation that was provided at Hauora Tairawhiti as well. The split around planned care and the specialties is in the report. I just put a brief update there around those key specialties that the question was about last month, and we can talk to those if required. And the youth funding that's been out to tenders have closed.
No, so it's not funding, it's the ERI to bring the groups together. Anyone have any questions on action items?
Sorry. It wasn't a question, it was just a comment about the performance dashboard. It was the third item under the October action items in regards to the adverse events in regards to immunisation to Hauora Tairawhiti. We have an undertaking from staff for the next hui or the hui after that to Tairawhiti eyes so that data, because the data that was presented was actually the national data, which was very, very low in and of itself. It was very, very low, but it was a bit difficult for us to think about what that harm may or may not be if it wasn't contextualised reaching it. That was my only comment, Madam Chair.
Thank you. Just on the update on the key specialties, I thought we might link that into the discussion on the financial report.
Mm-hmm. Sure.
Okay, so you note the update on the action items. Item 5.1, while we don't have any correspondence on the agenda, we do have correspondence from the Ministry of Health, and this correspondence is acknowledgement of Vicky and Heather for your completion of the full course of the Enhancing Governance Program.
Well done.
So well done. It was, I got to 3 of the 4 sessions. I couldn't make the 4th one, and it was, I couldn't make the 3rd one, I think, and it was really worthwhile. There is another set of financial workshops coming out early in the new year, so we'll make sure people get the information on those as they become available. And those workshops are all Ministry of Health funded. They don't incur any costs from us, and they're all via Zoom. So if we move to item 6.1, the performance dashboard. So Jim, if I can pass this over to you, please.
Yes, so you'll see right from the word go there, we're still having difficulty around enabling immunisation rates to rise again after the reduction over the COVID-19 period of time. That's certainly not for the want of energy being applied to that. And we have got a session with our primary care partners this afternoon, in which we'll be raising that again with them about what their actions are around that. We know it's difficult out there, in that recovery period of time about getting people back into systems and processes that they would have been part of prior to the whole COVID-19 period, but we can't keep on harking back to that. We just need to get back in there with families and increase those rates again. The rate of newborn enrolment in general practice, we've had some very encouraging information from the PHOs that they expect that to rise dramatically, double probably in the next month or two, and that they discovered a problem in terms of reporting, so that's very useful in terms of attending to that.
That's good to hear, because there was questioning about the processes in maternity for a while, and we were doing lots of additional reporting and contacting the GPs to find out that the mothers were actually still registered with the GP practices, and that wasn't a barrier. And we couldn't find any, resolution to it from our side. So it's good that they've continued and found something.
Just coming on a little bit further down in relationship to bowel screening, we're several months into it now, so it should be soon we'll be able to get some reporting around that as well. And those issues in that table there around both cervical screening and breast screening are, if I'm wrong, are system level measures. Nicola, certainly at least, yeah. So we do expect the PH. So those are ones where the PHOs have taken those on to address in this year. So we do expect them to make some progress in those areas as well.
Yeah, there's a little bit of an issue with breast screening because the provider is not local. And we have the ministry indicating we should be building relationships, but we don't have any handle to do that with, and we've pushed back to ministry on that really to request inclusion with them on those discussions.
What do you mean breast screening's not local? The provider's not local?
The provider's not a local provider, it's coast to coast, which is a lower North Island group.
But they're providing the service here.
They provide, we don't fund it, we don't directly fund it, the Ministry of Health directly funds it. It's a different setup.
So is that different again from the TRG updating that works out through us? Is it?
Yeah, no, sorry.
Yes.
Breast screening, Aotearoa actually works, that's where we go to get that component of our service.
Right.
They're a subcontractor to the provider.
Right. Yeah, there's quite a few hoops to jump through.
Sure.
Yeah.
It's been a long running issue.
Does the bus still go up the coast?
It does. But
There's a batch attached to that, I think.
It's not frequent.
yeah, it's different parts of the system working without us having an oversight of what that system provides to us, and with us having very little leverage in terms of what we might have with a local provider or someone who we've got direct oversight.
Right after the eyes, I think.
Yes, next, we have been in that space, we've won a few, so maybe we'll win this one as well.
Yeah, well, if the ministry is the one that has oversight of the arrangements with the Screen Aotearoa, then it's important that they're involved in those discussions.
Yes.
Just down the bottom page there around ambulance sensitive hospitalisations at 0 to 4. Ambulance sensitive hospitalisation rate is decreasing again, and we still expect that to come down quite a lot when we get up to date figures around that. So that's good.
I've just got a question on that. I didn't quite understand how these figures work. So we've got 0 to 4 Māori, 7,177, but total population 6,387. Does that mean the rest of the population
is much lower than the 7,177,000 per 100,000 population? Yeah, so the average comes out as 6,389. So that means that the non-Māori population will be much lower than 6,389.
Right, okay.
Yeah. So there has been some improvement on last year, but you can see that our target is much greater improvement than that. Again, a system level measure.
No, that's my mistake. I wasn't reading it as per 100,000.
Yeah.
I'm going to ask you a really stupid question, but what does ambulatory sensitive hospitalisations actually mean?
It's not a stupid question. So these are a set of designated hospitalisations that are sensitive to prevention in the community. So, with good primary care and good access and good, other aspects of, these are kids that don't need to be in asthma and things like that, that you can prevent admissions for. constipation, gastroenteritis.
I just have a question under the health and addiction services. I know we often say the word addiction, but do we break it down? What are people mostly addicted to, as far as data goes in this region? What's the main addiction?
It'd be alcohol.
It is.
Yeah, alcohol.
By number, yeah.
So that's why there's so many. What's that one there? Percentage of alcohol-related ED presentations. So I see it's up, but
Yeah, that's a specific measure put in place to look at the presentations within the emergency department of people who are under the influence of alcohol at the time of presentations in the emergency department, particularly looking at younger people.
So that includes not necessarily alcoholic poisoning effects, but just the was at a party overloaded, stepping like a bomb,
Yes,
cut
exactly.
type thing, all of those sort of things. So alcohol in the system.
Yeah. Yeah. Yeah.
So that's the broader alcohol harm rather than just the narrower alcohol.
The 3.1% of total population, is that based upon total population in that demographic, 10 to 24, or total population?
Really looking?
Is that the emergency?
The ED department percentage of alcohol related.
That is the. I think it's the total population. I'll check for you, Tony, but I think it's the total presentations.
Presentations.
So yeah, so 3.1% of presentations.
Oh, okay.
In youth.
So when it's saying total population, it's youth youth presentations.
And it's self-answering.
Anyway, so it's 3.1% of the presentations in the ED for this demographic.
Of 10 to 24-year-olds
Yeah.
are reporting alcohol use.
Yeah. So the 3.1 relates to the numbers of actual admissions or presentations at ED.
Yes, because
right. So 3% of our people coming through the door of this demographic. Okay.
would we break that down further and respect that a 10-year-old, like in that younger space, or is it just the 10 to 24?
The measure is around 10 to 24-year-olds, and it's hardwired into the system so that it's a mandatory field for any 10 to 24-year-old that attends the emergency department to complete the documentation has to be asked if there's use of alcohol, then it has to be entered into the system.
You really could do that split at 10 to 17 and 18 to 24, because obviously 10 to 17 illegal drinking.
So maybe that's something that we can bring up, alcohol harm.
Yes,
Yeah.
It is about alcohol harm rather than illegal.
No, but I mean,
to it.
but yeah, we've got half the people underage presenting. It's still a strong indication of the problem in our community.
Because I guess for me, I'd be interested to know how much more we can add to education around alcohol harm, but also fundamentally alcohol still continues to be our biggest causer of suffering across New Zealand, I guess, but other drugs are in the mix too. So I'm just interested to know how are we getting better?
We've got an exciting paper coming up.
So it's a measure about two factors really. It's a reality that the effect of alcohol on young brains is particularly a problem. So it's measuring how much alcohol is being, is implicated in this particular demographic of population. And it's also about the fact that education doesn't work for age group. So it is about harm prevention for that age group because education isn't something that is proven to work. So yeah.
But again, I think that's part of the alcohol harm paper is about data and evidence.
Sure. Yeah.
And that's something that we can tease out in a sort of sharpened discussion at that point. Are there any other matters on here you wish to bring to attention?
No, sorry. Yeah, I was thinking you were asking the whole room. That's right. Yeah. Pregnant pause there while I'm just. Yeah. Okay. Any questions? Yeah. Sorry.
Anything from any other members on the performance dashboard? Okay. Just on the finances, I think again we'll pull the performance dashboard part of the finance part of the performance dashboard into the financial report discussion. And so now we go to 6.2, my report. Just a few things to touch base on. National chairs met with the Minister in Wellington a week or so ago, I think it was. Days are kind of bleeding into each other at the moment. We had a broad discussion on the health system review. I think the main take up for this session is that detailed decisions are yet to be taken by Cabinet, but we will be having a further discussion on that later in the day. Other key points made by the Minister were on business as usual. He wants a real emphasis on planned care. On financial performance, he has said that progress is actually being made towards managing financial pressures, and the first quarter results across DHBs was better than projected. He is expecting ongoing pressure on emergency departments and mental health and addictions. For the associate ministers, at that stage, he was still finalising their delegations on what part of the portfolio they would look after. And I don't know that that's been finalised as yet, Jim?
I haven't heard that.
So on capital projects, so chairs had previously raised with Minister Hipkins some real challenges in getting capital projects through the approval system at the ministry. I think that for smaller DHBs, it's been much less of an issue than for big DHBs or for DHBs that are doing a full hospital rebuild. And some of them have had, several years to get a business case through and multiple millions of dollars to get all of the work done. So he is very aware of that and is looking at how to streamline and expedite the business case process. We did raise with the Minister our concerns that over recent years we don't get a good signal on our finances for the forthcoming year until budget day, whereas previously we used to get a much earlier signal and could, run our planning processes in a more considered manner rather than a gallop to the finish at the end. He was receptive to that, and so we're hoping that we may get an earlier heads up on what our budget for the forthcoming year would look like. And on workforce, and this is particularly for all your staff in the room, he really acknowledged that the system asks a lot of you, and that was good to hear that the Minister actually does see that. He sees some real challenges for workforce going forward, particularly the pipeline, and we're not bringing in the cohorts of particularly IMGs that we used to be able to bring in. So he does see some real challenges there, and also talked a little bit about employment relations. Then at the all of chairs meeting, there was a few technical things that we talked about, one of which is on our agenda later in the meeting, but probably the great thing was, so there is a chair of chairs, and that has been Jenny Black from Nelson. So the chair of chairs is coordinates all of the chairs, is the touch point for the ministry and for national issues and that kind of thing. And the Māori chairs this year nominated Cassandra Crowley from Taranaki, and she has been appointed chair of chairs. So our Te Manawataki region is now holding the position of chair of chairs. So we were really delighted with that. We nominated Cassandra because to our minds, she, across all of the chairs, is probably the most vocal and unflagging champion of equity. So that's what really lifted her for us, and she is extraordinarily competent. So I did just want to let you know that that she is chair of chairs, and she's probably known to many of you because she does a fair bit of stuff around Gisborne as well. On Te Manawa-taki, so Ngā and I are still jointly chairing our regional group of 5 DHBs, although Ngā has been doing most of the chairing, and I'm extremely grateful for that. So while we technically joint chairs, Ngā has very much been holding the leadership role in that. So Ngā, is there any update you want to give from our recent Te Manawa-taki meeting?
No, I think you covered off. Just to say, just to reinforce though, your quarter around Cassandra, absolutely dynamic person she is, and I think we'll go a long way with her as the chair of chairs. And unlike Meredith, she's a natural redhead.
This is natural.
It's actually orange and pink.
Hi, thank you. So
is that your real moustache?
It is, and it's the longest I've ever held it on a November, so I'm doing okay.
Might be reasons why.
So Ngā and I will continue to hold that chair role until the end of March, and then the baton passes again. So we're doing a 6-month rotation across all of the DHBs. So has anyone got any questions?
When the Minister was talking about focus on planned care, did he mention the extra putia involved?
No.
I noticed that in here.
No, it was his first outing with all of the chairs, and it was sort of quite a high level discussion. Jim, is there anything you want to add to discussions with the Minister?
No. I think you've covered that off, because a chief executive joined for a shorter period of time, and that was just really some of those messages you passed on about the efforts that DHB staff have put in over the period, and wider health system staff have put in over that period of time, which was very good to hear.
So in his acknowledgement of that, an expectation of staff, was there a look to how better to do wellbeing for staff working in the health sector?
So that's really our responsibility, not the Minister, as the employee.
But I was just wondering if he was giving you a noted to.
No, it was really more just a real acknowledgement that this has been a tough year and a lot's been asked, and it's not just that we're asking a lot from those we have, but we're bringing in less, so that's creating even more, more work. Okay, then we'll move to 6.3, the report from the chair of Te Waiora o Nukutai.
Kia ora tātou. I've only got a couple of 3 or 4 bits and pieces to put into the mix. Josh and I are still talking, working closely actually in terms of the alignment between Hiwi Te Rangi and Te Waiora o Nukutai Memeha. I think, Josh, it's gelling quite well with our 2 committees meeting back to back, and trying to take the pressure off of Nicola and Jim and the team from presenting twice. We're trying to get us to sit in the same room together so their presentations can work together. And yeah, I'm going to have a talk with Nicolette shortly about the next meeting. I just wanted to touch on one of the papers that are coming before us on page 55, Kia Tōtika Te Tū, so the mental health and addictions paper, which is coming up. I just wanted to make mention of the work that went into help develop the engagement process with iwi, well, both runanga in this case, but certainly a wider spectrum of iwi, working between the machinations of mana whenua, tangata whenua, and resident iwi. So we're still working on that part. We are also looking at individual training development for members of Te Waiora o Nukutai Memeha, particularly thinking going forward in terms of the Simpson report. So if we do away with, or not we, but if they do away with elected representation, then we're going to have a nucleus of people who are able to step up for consideration for appointment to whatever the new shape looks like for DHBs or any of their components put together. So that's one of the other discussion points. And probably lastly, we're losing Melissa Quimple, who is our secretary. So bugger, actually, bugger. I think she's leaving the health system altogether and going across to gardening outfit.
A small local gardening outfit.
Yeah. I'm just also going to just say, Kim, if I might, I'm just going to, rather than popping in and out, I'm just going to type out my stuff and send them on our papers today. So I'm just going to send them through on what do they call this thing? Not email, Zoom chat. And there's the first one. Hopefully. Oh, there's a whole lot of it. I've doubled up. Okay, thank you.
Thank you, Nga. Kia ora. So we'll move to item 6.4, Chief Executive's report, please.
At 9:15.
At 9:15.
Yeah.
Kim, we did have some guests here for presentation. We did have some guests here for presentation at 9:15.
I've jumped straight over that.
Yeah.
I'm sorry to hold you up. So we'll just wait for the Chief Executive's report. Would you like to introduce our guests and bring them forward for
Sure.
presentation?
I'd just like to introduce 4 of our team here who have been working very closely with Manaaki Tairawhiti over the period of time. So I thought it would be a good opportunity for them to come along and just talk in particular around the work of Manaaki Tairawhiti as it relates to health and the intersection between health and the wider work of Manaaki Tairawhiti. So from left to right, we've got Nicola Barrington, who's our current acting clinical care manager of mental health services. Dallas Haynes, who is our health broker. Dallas might tell you a little bit more about what a health broker does.
Benita
Mackey, thank you, who is providing admin and support for our school dental service team or oral health team. And Nikki Deva, who's our clinical care manager of women, children and youth services. So I'll
over to you.
Hand over to them.
So thank you for having us. So I apologise for some of you that may have heard this before, but we haven't actually formally presented at this forum, so bear with us. My team and I are here to support together, so I will lead us through, but at any time they might interject. And there's time for questions at the end, I believe. So, yeah. So what we wanted to present today was the Manaaki Tairawhiti way of working, which is a combination of kind of years of cross-sector work, whānau research, pulling all of the information, the stories from whānau, children and young people, and cross-sector together to form a way of working that resonates across the sector. So we're here as DHB staff, but we're also health leaders out in our community. So some days we don't talk about that we're part of the DHB because our way of working is that's our mahi and that's our values and beliefs about where we work on a daily basis. Next slide, thank you, Rachel. So how many, I'm imagining everyone's familiar with Manaaki Tairawhiti governance. Everybody in the room?
It might just be useful, given that we've got members of the public here as well, to just give a brief overview.
Yeah, John, can you talk to that? Because it's you sit on Manaaki governance, it's probably appropriate that you can talk to that.
Yes, so Manaaki Tairawhiti really arose from a communication from Selwyn Parata to our local MP and Minister for Social Development, and Tolly quite a few years back, around the growing work that was happening here within Tairawhiti between iwi, government agencies, the district council and others to improve outcomes for people within this district. And that then grew to Manaaki Tairawhiti coming together, and also at the same time government at that time was investing in some trials around this joined up way of working, and ourselves here in Tairawhiti, in South Auckland and in Taitokerau were the 3 areas of the country that were selected for that. So that was the sort of genesis around it, but it was built upon a lot of work that had actually been happening for some period of time prior to that, and has since gone from strength to strength in terms of the range and the amount of work that is going through Manaaki Tairawhiti, and more partners have joined in over that period of time there. But as an organisation, Hauora Tairawhiti has been there right from the word go, and I'm on the governance group for representing this organisation.
Thanks, John. So Nicola and I have worked together over probably the last 9 or 10 years. Nicola was the lead for Child, Youth and Family, and then subsequent the Children's Team Director. So obviously our relationship in community and mental health is already there, but Nicola has been kind of front and centre over the years of kind of part of those sector discussions where we talked a lot about what whānau were telling us, and there is literally over 500 stories I think have been collected in actually a publication and a children's team desk stand, etc., who kind of drives that forward. What we've got at the moment within the system is over 13 navigators who, if the 50 families have kind of grown, it's not 50 families anymore as I understand, but they've actually grown the navigator role. And part of the navigator role is actually to tell us what's not working or what's working in the system. So that pie graph, and some of you that are a bit closer, health comes, is health the yellow one? Yeah. So looking at what obviously the high health needs, so you've got kind of basic needs, health needs, housing, a whole lot of things, being able to navigate through systems that over 700 needs have been expressed by whānau from the navigators working in our system. But I'll just hand over to Nicola to talk about some of the other research that's been done through Te Pāhara and other forms of
Sure, kia ora. So just to take a step back to, I guess, as you know, Jim, Manaaki Tairawhiti has embarked on a system improvement change program, a methodology to inform how we capture whānau voice and demand and look at system improvement. I guess transformation is something we still aspire to, but in this journey, improvement is what we're working on. So based in whānau voice, some of the work that's been done over more than 5 years now, particularly with tamariki and their whānau, what do they need from us, the ways in which they ask us to work with them. And they're all the things that you will have seen over time and heard from your own whānau or seen in reports. But Tairawhiti, I guess, is really charging itself to make good on this, actually act on it. We've had a lot of kōrero around what those voices tell us. We need to move to actioning that. So there's support through Te Pāhara, the narratives, the voices of whānau, and there's some documentation that reflects that. But importantly, cross-sector within Manaaki now, some of the big ministries have been embarking on system improvement method that continues to demonstrate and profile and, I guess, expose what is it that whānau are seeking and what are the barriers to their achieving success, to achieving wellness, to actually getting support from the system that they're seeking over. Yeah.
So 3 years of kind of talking and gathering, we decided to put something on paper. Because what inevitably happens amongst organisations is there's lots of talking and lots of reports. But how do you put something together that's conceptual, that actually the workforce and itself? So Dallas is around some, what I call it's just really a concept. So the back page is really what we're doing, what we've learned. So Dallas and Vanessa can talk to this a little bit. So Nicola's already talked, if we start on the top left-hand corner, about the evidence, what we've actually gathered, some of the barriers through talking to families and mapping out their journey, sometimes over 5 years. One of the biggest barriers is around agencies not sharing critical information. So no surprises there. That's why Aorangi Tamariki, previously Child, Youth and Family, we've had some terrible adverse events, and some of the, I'm sure the learnings came out of that about people not getting the right information. Enduring wait for whānau. Dallas, do you want to talk to that?
I think I'm lucky having worked in the DHB for several years now, understanding how the systems, the patient information systems work and how they don't work. So I'm able to understand when we're trying to support a whānau in the community, what do they need from health? And I have been able to, navigate that through the health system, speak to the right people, get the information, because one of the things that does rise a lot is how are whānau enduring the wait? How long do they have to wait for us to get that information? If we meet on a Monday and we say, right, we'll come together next Friday and present that information, that's a long time that whānau have to wait for us to decide, what do we need to enable them to flourish? So that is always what drives me, is having the right people at the right time, the right information to do the right thing to reduce the enduring wait times.
Dallas, you just want to quickly just briefly mention what your role is?
So health services broker, so I broker. I don't sell health, which is what some people think. I broker health information between the DHB and everyone else.
How many are there of you?
Me, just me.
Right.
Yeah, it's just me. So we alongside the children's team as well.
The role, if I can just add,
yes,
the role actually came through from Te Pāharakiki, from the children's team section, because actually navigating across the whole system, including health, was so challenging. We actually had to put brokers in place to enable that to work. I guess the vision is that over time, you have a workforce that works in that way with whānau voice and whānau permission. But in the meantime, we actually have to facilitate it.
There's challenges around the different patient management systems that we have in the different areas. So it's pulling all that together as well and knowing where it is and how to get it. And that can be a barrier, but we can overcome that by understanding how it works. And
Dallas, can you give us an example? Can you give an example of your role?
So I work every morning. I get the family harm list, and I go through that list and identify anyone that is having ongoing health needs in the DHB, who's working with the whānau, so that we can there's a better understanding of what the safety plan is or what the plan is for whānau to help families, identifying who's our most vulnerable, I suppose, and what information do they require that's relevant to support them out there. So, what we're trying to do as well is reduce all the cars on the driveway. So you've got family, and there might be a family of 6, 3 of them have health needs, some have other needs, and we've got 10 cars up the driveway trying to support them. And I think what they've seen through the voice of whānau is that too many cars and people just shut the door and go, no, we've had enough. So it's like, who's the right person? Who can we get to be the lead? Who does the whānau want? And if they need support from me or from anyone else, then they can.
And helping to reduce the system barriers. So we talk about mowing down the barriers between, it's often wait lists, it's access, it's information. So trying to get rid of those barriers to make, things life a little bit easier. Yeah. And also working with the children's team to identify who is referred in and actually what information do we know, because we don't want people to go down and make assumptions about diagnosis or other health issues when we actually can find out the real facts of that.
I was just going to ask, in your role, do you feel like there are any gaps in the community within the services? Do you feel like you're able to get the right support for the families?
Yeah, I think so. There's brokers in each agency, so and we've sort of like a little team, so we can, with any whānau that they're working on, we sort of meet regularly or email or phone each other up saying, no, we've got this whānau and we understand there's an issue for them in health. What can you tell us? So we go by consent. Just a really quick example of a whānau We're having, they agreed to a test and learn sort of case study with Whanaia, and I was able to gather the health information for that test and learn case, and the health information actually got the Whanaia team to go, wow, if we had have known what was happening for them in this space, we probably would have been and treated them quite differently. They thought the way they approached the family would have been quite different if they had have known what was happening in health. So that's sort of where I come in.
So it's the overarching methodology you're looking at to get whānau self-determined, like, because our biggest hope is for whānau to take, be responsible, but understand what they know, like how much they know, because they've had agencies that been just so on.
Yeah, we can't assume that people understand. If I went to WINS now, I wouldn't have a clue what they're talking about. If people come into health, they wouldn't have a clue what we're talking about. So that's where brokers come in, and we can sort of extrapolate and, interpret.
Mary, this slide, which the team's worked out on the left, is a framework that came out of the work with whānau going to Tairawhiti, but it's held us in good stead, and it speaks to what you're describing. Whānau that, particularly Te Paharu Kiki were working with, had a range of challenges in their lives. So that pathway from building resilience, having access to information and interpreting. Not do for, learn. Okay? So as we move through, the expectation is we're also revealing their potential, their capability, building knowledge and skills to actually navigate the system themselves. But in the meantime, we've created such complexity and then gaps and barriers, very challenging for whānau to think about their holistic needs and actually have those needs met in an evolving way that they can own and drive.
Yes, because I get frustrated when I constantly hear about resilience, like we're such a resilient people, but we're tolerating, adversity. Like we're getting to a point where it's just a standard part of our lives to cope with. The biggest question I get asked is when we talk about the learnings, recent time of losing people in the region, the pre-story, a family member died, what help mechanisms were set in play and to that led up to, unfortunately, this more whānau had died. So there's lots of questions in community about what was happening in the health space when an incident occurs and the death of a family member.
And that's on the top right is your whole system work. So we do respond to the needs across the sector in real time. But often there is a sit down with a group of different agency people going and, with the whānau included in that and saying what was the information that could have helped us understand your needs better. So this is a learning system. So what we're trying to do is Manaaki Tairawhiti way of working, Manaaki Tairawhiti governance have spoken, they've given a mandate about this way of working. But it's been slightly invisible sometimes, so across the sector. So we've just decided to put this as a tool for the workforce across the sector, not just health, to understand how we can do things better. And obviously there's Hauora, there's Te Whare Tapawhana, there's Beslow's hierarchy of needs, because if you don't have a house, so you go in to do therapy and you find out that the person's going to be evicted tomorrow, you're not going to do the therapy, are you? But that's sometimes how we program. So this is about saying you deal with the needs of that person and the fact that they're going to be evicted from their house tomorrow. It's about doing the right thing. So we have, we can integrate contracts. We have one with Child Development and Ministry of Education. So we have one therapist per whānau. Otherwise, we could just go along with the criteria that the Ministry of Ed have a contract and the Ministry of Health have a contract to work with kids over 5 or at school. No, we integrate them so they have one therapist. And if you come from Auckland, you might have 10 therapists. So it's doing the right thing and looking at how we can improve the system rather than doing what we've always done. So this is just a pictorial of years and years of work and whānau telling us what they want us to do better.
Is it easy capturing the metrics on this one? Because I imagine it's quite challenging and a little bit nebulous.
It's really deliberate timing, actually. There's the methodology that's been developed over time with Manaaki. You literally capture the voice and you're theming and you're building barriers of information and actually the learning system going. So the executive team within Manaaki Tairawhiti drive there, and then you've got corrections, MSD, OT, all with a lot of expertise. We haven't applied the particular methodology of systems approach here in Hauora so much, so I guess some of us are very familiar with it. But yeah, very, very deliberate, quite time consuming, as you'd expect, eh? Yeah. And I've got a business analyst now to assist with actually really building a body of knowledge.
Yeah.
That's the other thing, that we're often reliant on other metrics and other knowledge. We're actually building a body of knowledge that's owned by Tairawhiti, by our whānau. Yeah.
That's cool.
So just a bit of a summary. So obviously collaboration, collective information sharing and response. So it's not about everyone going off on their own walker, and actually people need to come together. Even if I have talked to a mum recently who's got 11 agencies she's navigating. So it's about the collective response. It's not about 11 different responses. So we're building a learning system, we've got that, and we'll ensure that we improve as we go. Thanks, Rachel. So in 2015, a cross-sector group of agencies, we of course got together and talked about what is the shift in practice we need. Now, none of this will surprise you, but in 2020, we're still having to grapple with this. And it becomes what way, so we talk about whānau focus, but often we make agency decisions. So that's our challenge across the workforce. A partnership, multidisciplinary, and people have heard me go on in our leadership team, that is outdated now. We need to be moving towards a bit of more skill sharing and a safe scope of practice within some areas. And evidence-based practice. What are the common practice tools we can use across the sector so we don't have to do 10 assessments and 10 plans? What are the common assessment tools we could actually do to support whānau so we don't have to have all of those different assessments? That's a bit about the shifts in practice, which normally sits on the way of working. Thanks, Rachel. So stories, we've covered a couple of them. I just thought Anita might mention a couple in oral health of stories where we're trying to respond differently and the way of working.
So our focus, we deal with children every day. We deal with children in pain every day. And the ways of working in oral health is that we do whatever it takes to meet the needs of that child at that time. In real time, we get whānau calling during the day the child hasn't been eating, hasn't been sleeping. Pain in the mouth tends to happen at night, so you've got a whole whānau up at night trying to console this poor child. They're not sure where to go, they're not sure on how much power they can give the child, they don't want to overdose their tamariki. Taking that urgent phone call and hearing that child in the background crying and going, okay, right now that's our prime focus. How can we meet the needs of this child? Who can we get in contact to make sure that child is seen? Within oral health, our therapists can only work to a scope. Anything beyond that is our private dentist. For example, we had a mum ring last week, and her son was that child screaming in the background for 3 days. This child had been in pain. We had given a special benefit, dental benefits number to the whānau to go to a dentist. Out of our scope, they couldn't get in. So the parents decided we're just going to try and manage at home. 3 days, child not eating, in tears. The call of how it was to us. So luckily we have a contracted dentist. That's been my first point of call, is working out where and how can I get this child seen so they're no longer in pain. And it's having that approach with every child, not just seeing them as a number or as another child, actually looking at the child as a person holistically going, how can we help you today? We have tamariki turning up in clinic and they're sharing their stories of their life, what's happening in their homes. How can we support that tamariki? Who can I help? Who can I reach to? It's great having Dallas in her role because she's a contact that I can call and say, hey, we've got this child of concern, this is what they're raising, we're going to work with the school social worker to see what's happening with the whānau, talk to the teachers. We've built really good relationships with our schools out there in our kura because fundamentally they are with these children every day. and we can support our tamariki in the schools by actually breaking down those barriers to get help for that whānau that, the whānau may have not known where to go or how to get that help. It's just making it easier and walking alongside our whānau and our tamariki every day to make sure that our systems that we've created are no longer the barriers, and allowing parents to come to us, oral health, about anything, because that's where we want to be. We want to be that place that, yes, we may be oral health, but actually we also can assist in other ways, and we'll do that and be that contact until we can get the service, involved, can help you in that pathway.
Thank you. So the alignment with the way of grouping the workforce and if we're designing a building or a quarry needs to align. Otherwise you're going to end up an agency-led building which isn't actually going to meet the needs of fund. So we're just giving an example of a piece of work that's going on at the moment. I understand the board might know about this, Jim, the Child and Youth Hub. So we're kind of still not at the point of building or refurbishing something, but just thinking about all of what we've talked about, the Manaaki way of working. So if it is bricks and mortar, then actually whoever works in there has to work in the Manaaki way of working. It's not taking your old thinking and our system barriers into working in a building, a co-location building. But if there were offices for some DHB and other NGOs or other agencies that wanted to join, they sit at the back, but one entranceway in one part of that building, and we will test this, it's not just what we're thinking, is that this is about whānau, children and young people's space. So Dallas has put a bit of a caption there. So you're walking into one of those entrances, remember the offices are out of sight because we're pulling for support from health professionals and other agencies. But this entranceway here is for whānau, and if they want to have a hui, we're going to come from our space. Yeah. So we will walk into their space. So that's just a concept that we're trying to kind of test around that way of working. Because sometimes if you go into an agent, and we were talking about Grey Street, which is not it's just an example of if you walk into the Grey Street building where the children's team, ministry lead and IRD is, there's actually not anyone to greet you. It's very difficult to find your way through that process. It's a beautiful building and we're all very envious. But I think the kind of aspiration is that there's someone that you don't have to walk through a pile of officers or other staff to be seen if you want to have a hui with your agency people, that actually the hui will be in your space that you've designed. It's not an activity centre, it's actually a place where you could come and hold a whānau or leave a whānau hui with the agency people supporting you. So that's a kind of a concept that we wanted to test. We have been told what people want and we need to kind of do some action. So that's it really.
What about a marae?
That's it. I was going to say, just alongside that is exactly why, it gives me shivers to think about health and working with other sectors. We could become like the marae again.
No, the marae.
Or the marae.
You got 16 in this rohi. I think for me, thank you for the overall presentation. I was always wanting to know whether we could lessen agencies. Like, no disrespect to those working hard in this space, but we at some point in Gisborne had over 300 agencies that we could employ. So I see there's 34 in this space, but because social work in our region has always been a very high employer and respect to, and I was always concerned that people working in that sphere are working with broken people who are going through some issues in life, etc. And you're reliant on that, so your business as such is mandated to try and help support them to get better. But do you close your doors when you did it? You've healed the people as such. So I was always wondering if we could lessen the need for multiple agencies by having a few as such to get up there. Yeah,
and skill sharing is really important and trusting that someone else might be able to do
yeah.
So those A4s have actually got something missing, so Jan will collect them up.
One more one. So maybe hierarchy makes it something else. For a long time. It usually starts with food and shelter. I'd love to see that at the bottom of your diagram, because people then relate to the finer motor skills of Maslow's, if you like, which is there. That would be my first. That's just a suggestion. Privacy laws. Are they a barrier that you're trying to need to break down? Is it something that challenges you on a daily basis? I'm just interested to know if there's a point where you go, oh no, we can't. There's these glass walls where you can't pass through.
Depending on what they're asking for, and the relevance and the risk of not sharing. So yeah, we are sort of governed by heavily by the Information Sharing Act, Privacy Act, that we can't share. So the optimal thing to do is to get consent from the whānau. And we seem to be getting a lot of buy-in from whānau. They want us to help. They want us to sort of collectively help them to move forward. So yeah, consent is the way that we can get it done.
So are they able to give you one consent that then breaks down all what's like? Or are you required to go every time you go to another agency?
Manaaki Tairawhiti consent that they can sign, and that can sort of cover.
And that opens all these doors?
Yeah, it's been
Okay.
tested over time, particularly for that reason. I guess, is it improving? Because I guess the challenge has been actually the providers and the interpretation of the legislation rather than farmers driving this problem.
That's what I'm saying. Yeah.
So I guess the efforts are around having a way that's understood as that's genuine, instead of a lot of integrity around it, and good faith. It drives sectors changes behaviour that farmers don't need to, but they do need to be confident that working within the law.
And keeping it safe. Yeah. Thank you.
Thank you very much for coming and speaking with us today. I must say what you've said resonates with me. So one of the things I previously did was sit on the Ministerial whānau Order Review panel, and the things that you're talking about are just exactly the kinds of things that came up through that process. The whānau centre, that the willing workforce, but the structural barriers in agencies, the interagency collaboration, do what it takes. All of those kinds of principles and approaches were certainly things that came up through that process, and it sounds really parallel to that. So, ngā mihi kia koutou. Thank you. Okay, so
person here that can cup of tea, Madam Chair.
What's up with one?
10:30, right?
I can do that.
So just we'll get back to our agenda at item 6.4, and just to remind us that we do need to stick close to time today, because we need to be finished with the meeting by 12:15 for general business. And that must be finished before 1 o'clock, so we really need to keep pushing through our agenda. So our aim will be to get the public session finished by 10:30 and have a cup of tea. So Jim, we'll pass to you for the Chief Executive's report.
Yes.
And then probably directly into the finance report.
Okay. So yes, the month we went much closer to budget this last month, which was an improvement over the first few months of the year there. And you can see that we are actually nearly $1.3 million behind budget consolidated year to date. Just included some of the reasons there where we are at. We have got some additional revenue that we haven't included within that. We've had the discussion around our phasing of staff costs for a number of times now, and that will flow back in over the rest of the year. And there is the quite extensive non-specific accrual that we're putting in there, which is actually at $600,000 year to date at present. So we are reasonably confident about the direction we're heading at the moment, although at the moment, when you come to the financial report, you'll see where the current estimate of year end is at present, but still expect that to change as the year goes by as well. There are just the usual conversations there around some of the drivers that are within the results there. We are still seeing that lower number of acute admits this year compared to last, although the burst of activity that we've had in the last couple of months has started to narrow that gap. So it was 9.1% down after 3 months, now down to 7.5% after 4 months of this year. But encouragingly, when you take out the really dramatic reduction in numbers of children admitted to hospital, which of course is a fantastic thing, there is also a reduction in the numbers of adults being admitted to hospital as well for medical in the medical services, but an increasing number of people coming in acutely for surgery. So you've just got those graphs there on trends on page 22 of your agenda. And you'll see there that 4 months of the year, 9-year analysis showing that dropping off overall, greatly contributed by the paediatric reduction, but also within medicine as well. And on top of page 23, the planned care comparisons. So while there was that very large number of discharges back in 2015, this is the highest year that we've had for planned care, and certainly surpasses other years in terms of the amount of casework or the value to the community of the amount of work that is going through our elective planned care services at present, which is part of our drive to catch up and to make sure that we eliminate those reductions of service that occurred over the COVID-19 period of lockdown and service reduction. We are just wanting to just highlight there also that some of our expenditure there is forecast expenditure as well. So in October, Pharmac estimated a higher amount of expenditure for us here in Tairawhiti on pharmaceuticals this year. This is community-based pharmaceuticals, and certainly higher than what we projected and what we use for budgeting. So that's just something that we'll need to keep an eye on as the rest of the year goes by. We've talked about immunisation rates, faster cancer treatment, just the one person not meeting the 62-day pathway, I think that's about by 1 day or maybe 2. So certainly a lot still that focus on wanting to achieve that. Planned care delivery. So I've said before that we are concentrating on getting the numbers of people who are waiting longer than 4 months for first specialist assessments and for treatment. Just highlighted the first specialist assessment waiting times. You asked for what does the picture look like between the various specialties there on page 25. So the main areas where we do have people waiting longer than 4 months for first specialist assessments are in those ENT or otolaryngology, as we also call it, ophthalmology and urology. So the work is focusing in those areas, mainly through putting in additional resources to be able to get to see more people. So that is driving some of our outsourced medical staffing expenditure at present to focus in on those areas. But of course, there is the additional revenue that we have got that you mentioned before, Tony, around addressing those catch-up requirements. The table at the bottom there shows that we've got those down from the peak of 174 people waiting longer back back in April and no, or May, and then getting that down. And just one graph there around the certainty we need to push on. We've got a shorter period of service reduction over the Christmas New Year period this year, and is also to enable us to keep the pressure on and keep getting people through.
Thank you for that table, by the way.
Sorry?
Jim, thank you for that table.
Okay.
That makes things very
that's just the FSA. So next month we'll give you the people waiting for treatment.
So just quickly, Jim, in next month's month, it'd be really cool to get just your comment on what it is that's causing the wait times. Obviously your first specialist appointments are being met with the exception of those highlighted. But when it comes to actually getting procedures done, is it human resource, is it equipment, is it wait times outside of the region that we can't influence?
So just going from left to right across those areas there, the big ones, ENT is capacity and numbers of people being referred through. So the numbers of people working through issue is one where we work with our GP liaison to identify some alternative pathways for people so that more of that work can be done within primary care and reduce the inflow so that particularly the surgical team there can concentrate in on those people who actually do require to see a specialist and those that do require to have surgery. So that's the area there. Ophthalmology, again, also capacity issue. So we have got a registrar working with the ophthalmologist who's able to share some of the load there and are looking to contract in some additional ophthalmology resource to be able to address that there. And urology, that is an area that is improving. We have got some better coverage now with our visiting urologists, and we have a nurse practitioner working within that team as well, which is greatly increased our capacity there. We found that last year or a year or so ago, we had similar problems in orthopedics, and you'll see there's zero people waiting longer than that. So we're able to increase capacity there. Utilising a nurse practitioner within that service helped us with that service as well. So we're applying that within urology as well.
Not just the nurse practitioner.
In urology? Oh yes, no, yes, well done, Director Valid Health and Technical. Yes, yep.
Just to try and excuse me. Jim, does urology present a higher risk? I mean, an ENT, no one's going to necessarily develop a condition and die, nor probably ophthalmology, but urology is.
Well, it's all. I think across all specialties, circumstances where there is a degree of urgency. In ophthalmology, we don't want anyone to lose sight. So that's a major disabling thing. So we need to be really careful around those people getting referred. So urgent work, of course, gets done in any case, but you can get deterioration in your eyesight over a period of time, and that's well-known cases where that has occurred. So we have to be careful there. Similarly, in ENT, there is a lot of people that get referred through for conditions that underneath that, what appears to be something, not so complicated or difficult, in fact, actually can, be a form of cancer or whatever. So you do have to be careful around that and making sure. So while there's a profile around in maybe areas like urology, all of those specialties deserve attention.
That's the first thing I did with removing my vocal polyp, was testing it for cancer. So.
It seems to me that that the tension on the wire here is that to get through this work, we need more people to actually do it. We don't have the permanent staff, so we bring in outsourced personnel, and we all know what that's doing to our financial position. And like that seems to be the fundamental tension, which it's, to my mind, if we can get permanent staff, then we can have the best of both worlds, and that's probably a longer term discussion that we need to have. So I really appreciated the update and the action points about recruitment that's rolling.
Can I ask, what does our DHB have any initiatives in place to do workforce recruitment locally, and like are we working with the high school students to try and bring them into this workforce locally?
Perfect management.
So I think a couple of things. First of all, I'd just like to say that Carl is extremely right to actually bring up the fact that we need people practicing top of scope. So we need more people, such as is happening with our allied health professionals around orthopaedics, so that more of the work is actually done. So we spread the load and the work gets done by the most appropriate person to do that. Same with the nursing or in many other specialty area, team working as well. So it's, we certainly do need, specialist doctors, but they need to be doing what specialist doctors have to do. So the things that can be done appropriately by general practitioners and other health professionals, then that's a strategy that we're absolutely keyed into. And Carl's really right to highlight the fact that that's actually what did happen a lot with that orthopaedic situation. In terms of recruiting people locally, there is a number of programs that we are involved with as a DHB. Hauora Tairawhiti is a national program which we are involved in terms of encouraging young Māori into health careers. So that starts right back from pre-birth, really, all the way through to opportunities within schools, and particularly taking science and supporting science within schools. We have got, just recently, have increased the amount of people working within the DHB around that program. We've got some additional funding where we lobbied from Hauora Tairawhiti program to increase, so we've now got 2 people working within the DHB. We put some money in as well ourselves to do 2 things. One is that Hauora Tairawhiti work and working with schools in communities around encouraging science and coming through within health careers. And we are also looking at another area which is around with bringing more training programs here to Tairawhiti at the moment. You can train to be a nurse in Tairawhiti, you can train to be a midwife in Tairawhiti with a bit of difficulty and support. But if you want to train as a physiotherapist, an occupational therapist, a speech language therapist, a dietitian, you need to leave the district here. And we know that that can be a barrier for some people to be able to enter careers, particularly those people who've got other responsibilities in their lives. And those are the people who we think would be very valuable to be working within the health system. So we've been in contact with Polytech around whether they can work with others to be able to bring some of those programs here so that we can actually get, as an example of what we're doing. The other area that we just, because we've increased the resources we have got, is around working with our staff who are Māori, many of whom are in roles that are in not professional roles, and that may, and we need to work with those people around. That may be the option that they want to consider and continue working in. But we're very mindful of, we've got huge potential in Tairawhiti as a whole, and in our employees and employees within other organisations who have got absolute potential to work and move into some of these roles, so that we are less dependent upon bringing people in from outside the district or outside of the country.
Yeah. Because I was one of those people that was able to get a grant through HIHA and got a laptop and my lactation studies paid for, and it was the best investment. And and I just think maybe we could be more strategic and target and be more intentional about who we can find, who, like you mentioned, have got a lot of potential, who are currently employed but need that upskilling.
Sure, totally, Amy, and that's exactly what we're doing. And I have suggested that I noticed that you, Nicola, brought a couple of your 2 new team members along to Waiunu and Taimeniha to introduce them about the work that they're doing. And I was thinking maybe whether it's at the board or elsewhere that we can get Donette and Taylor to come along and talk about the work that they're doing, because we just absolutely need to get into that real potential that we have in Tairawhiti. But to release that. It's as I say, it's a lifelong piece of work that we need to do. So the work that was just talked about, Manaaki Tairawhiti, and making sure that all of our young people in Tairawhiti get the best possible start in life, because that then leads on to being able to work well at school and have the support from your family to be able to do that, and then sometimes make that really difficult transition after you've, to be able to get into a training program, sometimes has to be out of district, and how we can support. And I know that that our secondary schools here in Tairawhiti do a lot of work to try and be able, well, not to try, to succeed in supporting young people to be able to make that transition and then come back home again for employment here. So we have...
It's getting them to come back.
Sure, but we...
After they've got qualified.
Yeah, we've got avid thirst for those young people to work within this organisation, and I know our health providers here as well. We have been most successful around nursing because of the fact of the training program here. We have taken all the graduates that applied to us last year, and we're taking all of the graduates again this year as well to match their enthusiasm and their work with us supporting them into this organisation. I need to move on, don't I? I just got a few things to raise within there, just to note that around the thing around oxygen supply and environmental issues, that we are moving on with that piece of work, which is around upgrading oxygen delivery for surge planning, and we need to have that completed by next winter, and also some of the environmental, creating more spaces that are negative pressure should there be a resurgence of COVID-19 next year or the next pandemic. And we have got a planning exercise that will be held before the end of the year around how that will work. Cabinet has made the money available for that, and there's quite a significant budget available to us here, depending on what the total costs of those are. I just put a few little quick discussion topics down there. We'll take my MAB demolition off there now. The mental health and addictions facility work, we are out to tender for the architects that will work with our team and all the stakeholders around that. That will be that ends I think very early in December. So we hope to appoint those before the end of this year, so we can get onto that next year. Nikki's talked a little bit about the Child and Youth Hub. We have got some significant upgrading of the radiology department that is going to commence before the end of the year as well. Equity we'll talk a little about in the paper coming up. Director of Nursing role, we've got a successful candidate for that, and the role of completing the appointment around that. Chief Medical Officer, we've shortlisted and are interviewing 3 candidates on Friday this week. Are our patients in the place, not all, we've got to finalise the issues around nursing leadership around that new structure and get out for that. And sustainability funding, we have around about $350,000 this financial year made available through Budget 19, which was around improving sustainability of DHBs, and that's going to be a combination for us of some baseline capacity around developing our work as an organisation, and some specific projects such as around the prevalence of atrial fibrillation within our community, which has obviously a serious health issue for our whānau within Tairawhiti, but also an impact on service provision within the DHB as well. Vaccination campaigns, just wanted to highlight there that between now and the middle of next year, we have a measles update for 14 to 30-year-olds. Bit of a lost generation there in terms of rates, and we see that as an opportunity to reduce the chance of spread of measles in the community, which is obviously very relevant for young children. So that's one. 2 is around the flu campaign for winter 2021, getting ready to plan about the rollout of that. And number 3, COVID-19 vaccination, which we have commenced planning around how we will do that. obviously there's some logistical issues there around depending on the vaccine available, and also who will be the priority groups of people who will receive the vaccine when it's available.
Definitely governance.
Only in that when we focus.
So a governance would have a yacht in Greece and want to use
So it
it.
won't be people aged under the age, what is it, age over 40, Tony? Yeah.
Emotional IQ.
Yeah. And then just wanted to highlight there, further on there, around the regional equity plan. Nicola is part of the leadership team across Te Manawataki for that. Anything happening you wanted to mention?
We recently met with the GM's Māori House, Ngātuka, the COOs of each district health board and GM's planning and funding to ensure that we were lined up and on the same page regarding the Manawataki approach, particularly on the initial pages outlining what was a high priority for the region. We've, while we're still synthesising work from that day, what we have agreed is a broader group on some of the definitions as we understand them to me, and identified how we would progress the work for an update to the Manawataki CEs and chairs. So it's the initial setup that we're about to launch into.
And last thing on my list there would be again about COVID-19, and that we are the regular updates coming through around testing regimes for, in our case, people at the port and our staff and those other people who are interacting with that around testing regimes being modified and updated on a regular basis. We are also concentrating in on rhythm and vines and some work around what we will need to be doing around that. And thank you to everybody who used your QR code, you scanned your QR codes and you came to the building this morning, and keeping up the work there, and the ambassadors for that within the community.
Just in regards to rhythm and vines, I was thinking about that event that was happening. Is there any coordination, I guess, between our organisation, say GDC, say those that are involved in, say, the tourism space, like Trust Tairawhiti, and in regards to messaging for those ones that are, say, coming here, not to say don't come here, but this is our community. Please make sure you're taking these things seriously. All of that kind of stuff. I think that it will be one of those things that our community may worry about, but I guess to put it into context, we've already had in this nation rugby games that have had like 30,000 people at them, etc., etc. So gatherings of large populations is already happening in our country, but is there any kind of coordinated organisational
there's a coordinated response for supporting R&D to meet some of the expected kind of legal expectations of how they run a safe ship, how they reduce infections, all that sort of stuff.
Yeah.
I don't know that there's been a joined up discussion around the messages out, but we are looking at what we will need to do in that space. So there's quite a high concern with the gatherings across the country, because there will be a number of other concepts about how we support each other. So Tony?
I was just going to say that something came through yesterday that all of government is working with, I think 20 identified events which Rhythm and Vines at the top of the list actually on having some consistent messaging. And so all of the agencies you mentioned, Josh, will have access to that messaging. And also they're working specifically with the organisers of that group. Yeah. So while what's coming from all of government isn't specific to Tairāwhiti, and I'm sure we'll add to that, there is something consistently coming.
Awesome, yeah, because it's a fine balance between fear and caution, right? You know, so we have to make sure that that's speaking about it properly.
The other thing is that messaging with with Minister Hipkins when he was still he is still the Minister of COVID.
Yeah.
And indicated that we were keen for some coordinated communication for the festival season generally.
Awesome.
Yeah, the public health units in those different areas where those concerts occur are all pretty much tied up with having to manage what their public health protection activities will be. So they talk to each other, but it's unlikely they're going to be able to share resources.
Awesome. Cool. Thank you. That was it.
Any other quick matters on Jim's report? Okay, so on the finance report, Jim, I just want to, before you pick up on this, just say that it's great that that the result is changing direction this month, but the forecast is something that I would like at the next meeting for you and Craig to have given some consideration as to how we're actually going to make that change that you mentioned and start to see that forecast shift back towards the agreed deficit. But I think we just need to give you and Craig some space to work through that rather than trying to solve it around the board table today. That was the main thing that I had on the finance report. So is there anything else you wanted to add to Craig's report?
Craig's just put a bit more information in there that was requested that we go into a little bit more detail around some of the areas there. So I know he's got some ideas further around strengthening that further. So that will fit in a little bit about what you're talking about in terms of the longer term focus there. You know, as I've said in my report, there is a few things that are driving that over expenditure at the moment. So those areas are obviously the focus areas. Our outsourced services are a particular issue for us at the moment, and the better we can get at actually being able to manage some of the pressures without necessarily having to have such a degree of outsourced servicing is important. But often that is around maintaining a roster, having a 24-hour-a-day, 7-day-a-week service available for our population, which is vital in many of those specialties. So that will be that's often difficult to get around. And the other area around, some of that change is there around pharmaceutical costs within the community that we will have to accommodate in other ways because it will be difficult and impossible to change the course on those things. But those are estimates that Pharmac have provided us at this point, and they still might change. We are having some success around being able to recruit people into the organisation. We are in what appears to be a different era at present in terms of people wanting to come to Aotearoa and Tairawhiti, so that is helpful. Thank you, COVID-19. There's a silver lining in the experience that we've all been through in relationship to that. And there is ongoing support from government around additional costs that are still COVID-19 related that we are experiencing in the health system for that.
One very quickly, Jim, it just jumped out to me, was overspending patient meals. How can we overspend by 51k in patient meals?
It may just be a timing issue of a relationship to so the budgeting is done on a different basis to which ways the bills flow in. So it may just be a month where you had three invoices in a month that was budgeted for.
Okay.
So
thank you.
We'll keep an eye on that. Cash flow is looking good at present, and you've seen the forecast there, and Craig's just included a little bit more information, presentations and ward admissions showing some of the increase that has occurred over the period of time that he's put in there back to October 2010.
So I think I'm of the view next month we should have a discussion about forecasting management, so that we are all aware of where we're at and where we're going. But I do think we need to just give some space for for the staff to work on that. So are there any other things that people want to raise on the financial report? No. Couple, thank you, Jim. Then we'll move to, there's no public items for reporting at item 6.6 from the board subcommittees. Item 7.1, at I think page 41, the equity outcomes activity. So this is a note in paper. So Nicola, is this you?
Yeah. So just to assist us to keep on track with the range of different areas that we're progressing working equity on, this is an update based on what sits both within our annual plan, but also as activities have been raised through the last 10 months or so. We've added in areas of new comment and giving you a bit of an update, brief as it may be, on where we're progressing with these areas of equity. So hope you can read it and take any questions or feedback.
That's a really good, very comprehensive. Thank you. It's a great report. It's really easy to follow where you're going with it.
I think I just have questions about the Mokapuna Ora and the Wahakura in homes of 50% of the population, and I think that's supposed to be the 3-year outcome sought. But I keep asking for what numbers of Wahakura have been distributed and made and things, and I can't get that information. So my maternity services are still funding the pipi pods.
No, we are.
Are you sure? Because it's been coming out of the smoking cessation money, because
it's our funding.
There's a refusal to fund these, which is, you know, the 7,000 sold, and the number of what I've been ordering hasn't gone down.
I think we should.
Yeah, that's
I think you guys can.
Yeah.
Yeah.
So the Wahakura program does have a reporting information coming back to the planning funding team, and we can do their replies.
So I just wanted to just note for the board that that a short lineup is meeting with the chairs of our iwi next week. So I think we talked about this a couple of months ago, that we were going to do this, and we've managed to get a date of Monday. And I know everyone's really interested, but because it's like only the chair coming from each iwi, I think we need to keep it a bit more balanced than having our full lineup. So it's just a short lineup of 3 or 4 of us who will be at that meeting. But that is to get principally a sense of what in terms of equity is important to our iwi partners, off the back of the equity needs assessment that was at the last board meeting. So just to flag that is coming up, and then we will bring that back into our annual planning process, which will be kicking off very early in the new year. Also, I just did want to and Jim will probably tire of me asking about this, but it's something that I think is I'm really interested in, is specialties going mobile. So, you know, we've got dental, which we're getting back up and running, and the ophthalmology clinic, and is it orthopedics that we were looking at doing, Jim?
O&G.
O&G.
Yes.
O&G.
Yeah.
So is that still kind of a one of the sort of broad equity approaches in getting services mobile?
Yes.
Is it very much more expensive to do that, or is that on the margin?
It's more around it's about having capacity and taking absolute best advantage of the time of you know, taking those specialist clinical teams out into the community and making sure that not only are they seeing people, you know, in those settings, but also working with the staff and the teams there around you know, sharing ideas, you know, both ways,
and getting those mobile clinics fully booked.
Yes,
when they're
yes, but
out and
also taking,
follow-up
in the,
arrangements,
between patients and lunch breaks and things like that, to actually be working with the teams on the ground on the coast, for instance, so that you can cross share information and knowledge, because both teams need to get that.
Okay, thank you for that, Nicola. And I think it's fair to say that that the board will be keen to keep getting apprised of where we're tracking on this. It's one of our fundamental priorities. So thank you. Item 7.2, kia tōtika te tū, mental health and addiction. So this is a noting paper updating us on public consultation on the mental health model of care. So that's you again.
Again, it's just a briefing to feedback to you where we were up to from our last meeting with the board, indicating we were meeting with a subcommittee of Te Waiora and Taimiha, which we did have, and we are progressing the approach they've advised us to undertake with iwi, and have further supported the work that we've done to date and the approach that we're undertaking as well.
Does anyone have any follow-up questions on this one? No. Then we'll get a 8.1 DHB position statement on alcohol-related harm. So this has been now becoming quite an enduring topic at the national level, and chairs get visited by public health specialists at every meeting who talks to us about alcohol-related harm. So it's clearly a very important thing nationally. So Jim, can I pass this over to you?
Between Nicola and I, we will talk to this one. As you can see, the board did actually endorse a statement similar to this back in 2013, but it would seem that it was not publicised beyond the discussions at that time. So we aim to, if you are supportive of this, to do something differently this time in terms of actually utilising this much more directly in the work we're doing as a DHB, and also with our other stakeholders within the community there, to reduce the impact of alcohol on our community. And we've already had a conversation this morning around that. So the draft position statement that you've got there is a common one to all DHBs. So, but we've made it a Tairawhiti document in there and put in the information around the Tairawhiti statistics to bring that up to be relevant for there. I guess it's there for you to talk about further, and it also adds in there a draft of a harm reduction strategy for Tairawhiti as well.
Yeah. There's high interest from Manaki Tairawhiti in terms of the work that's been underway with the regional funding as well, to have a combined addiction strategy underway. So its timing is very useful.
So just to clarify, with the strategy and implementation plan, they will be worked up alongside partners and come back to the board. That's right.
They will. So while it has a strong drive focus from public health, we are very much aware that there are stakeholders in our community who are very, very interested to participate.
That's great.
Yeah, so the group that looks after the model of care was expanded to include our partners from Manaki Tairawhiti, and that's police. It's also the new providers who will be delivering on those services, and it also has the broader component of providers joining with us. So that it covers the whole of the kind of service provision, and it includes consumer as well. So that group has become quite consolidated now, becoming the overarching group to support going forward.
Is council involved?
Through Manaki Tairawhiti. So we have engagement with council through public health, and we're quite heavily engaged with council in terms of the operational work.
You have to think of the regulatory aspect of it.
Absolutely.
Alcohol bylaws, yeah.
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 So our regulatory body and their regulatory body work together?
Regularly?
Absolutely, at regulated times.
At gin and tonic time.
Full support, Madam Chair.
I'm just checking, I think we actually mentioned in here working with other agencies who I also took to mean local government.
Yeah. I think it's been good to see more kōrero too, in respect to Māori and vulnerable people are disproportionately affected, where alcohol outlets are, you know, in respect to neighbourhoods with high proportion.
So we lost the Black Ball encounter last year.
Yeah.
Most recent, we lost it.
One question, one thing I'm just coming from a private producer angle in this. The very first comment around alcohol provides some benefits for the people and the economy in their district. Now, I'm guessing the economy part of it is our wineries and our hospitality venues. Yeah, right. So I'm just what I was looking for in there is the working with them, working with our producers, because they wouldn't want to see. I can guarantee that they don't want to see harm as a result of, you know, the beautiful wines that are produced in this region. So
how will that make sense in the strategy? And that's probably where it sits.
Would it not sit with the hospitality groups and of the association and messaging in terms of consumption, in terms of actual consumption and public? Yeah.
And you know, our producers are really clued up in this regard. You know, they're very aware of that. So I guess I missed that interface somewhere in here. I don't know where the best place is. I'm not smart enough to figure out where.
So again, I think that's something that could come in with the collaboration with stakeholders and communities and get fleshed out in the strategy plan.
Yeah.
But this is a fairly high-level touchstone, this particular paper.
Because you know, Sandra,
just acknowledging that there are those in our region who do produce beautiful wine, but are very conscious of not wanting to cause harm in the community.
Because you wouldn't want to, you know, inadvertently confuse the economic contribution that's brought about with our viticulture industry, when actually this is more about the consumption, the behavioural issues and the way in which people consume alcohol and the consequences afterwards. Does that make sense?
Absolutely.
But there's that balance of making sure it doesn't impact on the producers and their revenues.
That's what I'm saying though. It's quite, for me, I think it's quite clear, because this is clearly about consumption by individuals that you've got no controls other than regulatory controls about where they drink and what happens afterwards.
So I think, I mean, if we just look to the title, it's about harm.
Yes.
Yeah.
And that's the principal focus of this, rather than economic benefits.
It just undoubtedly, because we talked about our economy in that very first line, and I think interesting.
It also sets up in positions within the realm of harm minimisation and responding to addictions in quite a different way.
Okay, so it feels like we have support to adopt this position statement and agree with further work to be done with stakeholders on the strategy and action plan. Very good. Now, our last item in public agenda is our 8.2, the Ministry of Health Assurance report for Q1 2021. So this is our regular assurance report that we provide to the Minister that I think every quarter we do one, don't we, Jim?
Yes, we do one every quarter.
Every quarter, and the board is formally asked to agree to this so that it can come from the board. Does anyone have any questions or comments? Given that it's a board assurance. Very good. Okay, thank you.
We have our regular meeting with the ministry tomorrow. So I think I'll raise it again as to what actually happens to these reports.
Okay, very good. So that brings an end to our open session. So I now need to move the resolution to exclude the public from the governance of the meeting in accordance with Schedule 3 of the New Zealand Public Health and Disability Act for the reasons outlined in that schedule and in the Official Information Act, the section 6, 7 or 9. Do we have a seconder for the proclamation to exclude the public?
Yeah, the secondary.
Thank you. All those in favour? Aye. Thank you. I'd like to thank members of the public who have been with us today. Thank you very much for joining us, and we do continue to encourage you to participate in these meetings. Our final meeting for the year will be on December the 22nd. Good. So we look forward to having you join us then. Kia ora.
Kia ora.
Cup of tea?
Cup of tea.